Time somebody uses eminent, I know that I'm on my way out. That's why you have to take lectures like this now. Okay, so I'll spend the next about 8 minutes talking about lung cancer screening in India. Where do we stand? And then maybe some questions if we have to. So this starts with the basic understanding of screening, right? Screening is of two types. One is population, the second is opportunistic. Population screening is where the government or the National Health Service or insurance pays or underwrites screening for an entire population that deserves to be screened. So for example, breast cancer screening with mammography in most parts of the Western world, fasting blood sugar estimation for diabetes, screening colonoscopy for colon cancer. These are all examples of population-based screening, which typically occur in rich Western countries. There is no population-based screening in India, not one thing, right? Not fasting blood sugar, not measurement of blood pressure, nothing. So you can't expect radiology or oncology related screening to occur in India. So what does occur is opportunistic screening. That is when an opportunity presents itself to a system, a hospital, a group of people, or to people themselves to be screened or to get screened. Example, people who go for health checkups or physicians sending patients for tests based on risk estimation. So I think you have high atherosclerotic cardiovascular disease risk, and therefore I'll send you for LDL estimation or a calcium score or whatever it is. Or people and patients wanting to test themselves for breast cancer, or gynecologist saying you're 45, go and get a screening mammography done. That is opportunistic screening. So in India, all screening is opportunistic. There is no population-based screening in India. So let's talk about lung cancer screening. Where do we stand? The first thing we have to prove is that it works. And I don't think we need to reinvent the wheel in India for sure. It's been done multiple times across the world. It works. It saves lives. It picks up in high-risk patients, those who smoke more than 20 pack years and actually even lesser, lung cancer at a stage where by treating it, you extend life. So that part works. And we've been doing it for about 10 years. We've published a small proof of concept study, and that hopefully would have led to more studies, but they're not going to happen. It's too late for that anyway. But LDCT saves lives. So why has LDCT for lung cancer screening not taken off in India? Lots of issues. Inertia, just the fact that, when you need to start something, you need somebody to push you. We don't have driving forces. We don't have a single person or an association that's decided we will take this up and we will push this and we will try and get people to use LDCT screening. It doesn't work somehow. There are perceived radiation issues, which sometimes in the minds of policymakers are difficult to get rid of. Everybody talks about the endemicity of tuberculosis, which can confound the results of LDCT. But the Korean studies have clearly shown that's not a problem. We cannot underestimate the fact that radiologists are reasonably good at figuring out what is or is not significant. And we should have that faith in the training that we could train enough radiologists to be able to do so. Lack of a smoking history, because we don't have good EHR systems, perhaps the ABDM that has been launched by the government after 5-10 years would allow that to happen. But currently, patient comes for a CT chest, the radiologist doesn't even know the smoking history. So for the radiologist to push the patient into a screening program by just giving it as an LDCT report cannot happen, because you don't know whether the patient is a smoker or not. So that itself is a problem. And then, of course, while I did say we should have faith in our training of the radiologists, currently the situation is that in anybody, even a 70-year-old smoker with speculated margins, your report will start by saying likely to be of infective benign etiology, wait for 3 months, give antibiotics, some kind of rubbish like that. So there we do need a little more training to kind of turn it around to say 70-year-old smoker with a spiculated nodule likely to be malignant unless proven otherwise, and get a biopsy done. And then obviously cost, everything in India boils down eventually to cost. But there are people who can afford, the country cannot afford, and that is the difference between population and opportunistic screening. And then unfortunately, we have these kind of editorials. So this is the conclusion of an article that came out that kind of said all of this, that though there are strong shreds of evidence with few limitations, etc., TB, sarcoid radiation, it doesn't work. Another one from Delhi PGI put together, same thing, ideal screening method. This is not because A, B, C, D. But both these sets of authors, the one thing they haven't understood is the difference between population and opportunistic screening. All these statements are made to say that LDCT cannot be a population screening tool. And I agree, it's the same debate. Breast self-examination or clinical examination is as good as screening mammography from a cost effectiveness perspective. Yes, if you were going to use it as a population screening tool, perhaps in a country like ours. But if a woman who earns ₹100,000 a month wants to get a screening mammogram done because the data is that it saves lives, you can't deny an opportunistic screening to somebody who can afford to get it done. And that we always mix up and mess up. And that's where the problem arises. So India cannot afford population screening for any disease at this stage. We don't have it. We can't even do blood pressure and fasting blood sugar. And those two are the biggest killers in India. Forget oncology. That comes really, really low down on the list. So if all screening in India is opportunistic, then opportunistic screening is not difficult. And that is something we need to work on. So what are the things that we can do right away? Every physician who sees someone with a 20 or even 18, 17 pack years history can advise an LDCT study. Patients who can afford will get it done. During COVID, we made 50% of the country get CT chests done. We can do this. It's not possible. Every hospital can institute an LDCT program, make brochures, standees, etc., give them to patients, to people in the rooms. It's all doable. All diagnostic centers and hospitals that offer health checkups can create a package saying smokers package or high-risk lung cancer package. And like you put calcium scoring now as part of a health checkup or cardiac CT, put an LDCT. No? That's also doable. Whenever a radiologist reports a CT scan in a smoker, if you see emphysema and you don't even have the smoking history, use an LDCT report format and then use a lung RADS and put the patient as part of screening and say, as per protocol, next screening is after 1 year or 2 years or whatever it is. Automatically, you've created a cycle whereby even if 20% of those patients look at a date and come back for a follow-up, you've instituted an opportunistic screening program. And the same for all those who do tobacco and de-addiction programs. They should also start doing this. That's pretty much it, right? So we should start small, but at least let's start. I mean, it's been 10 years since we started and that's it. We're still the only ones doing it. And it sucks. I think there is a lot more that we can do. It saves lives in smokers. And I think that's something we should be doing. Thank you so much. So questions, we have time for a couple questions.
What is your opinion on screening of big 3 or big 4 in the sense that how much of the CAD calcification should be put on the non-gated scan? Does that add like?
Yes, we report. So just calcium, no calcium is good enough.
It says at least mild, moderate, severe.
Yes. Yeah. So we are using AI to actually quantify. It works really well.
Even for the non-gated?
Even for non-gate. Yeah. But in the end of the day, it's just no calcium, yes calcium. That's good enough. So we do that. Okay. Sure.
Thank you so much, sir, for giving us the roadmap on how to start lung screening in India. And now